and the people connected from remote. I think we can start this seminar. Welcome. My name is Corrado Barbui. I'm a professor of psychiatry here at the University of Verona, and I'm chairing this seminar that is the closing seminar of the Marie Curie project of Davide Papola, who is here close to me. The idea is to have a first guest lecture from Vikram Patel, just to give us kind of the context of what we are talking about. And we are talking about mental health care, the provision of mental health care in a poor resource setting, and then to move ahead with some experience. We'll have experience in conducting clinical trials, experience in aggregating the data of clinical trials into systematic reviews, and then trying to dismantle this data, having the focus of optimizing and personalizing interventions for each person. This is the general idea of the seminar. So the first speaker is Vikram Patel. Vikram is professor and chair of the Department of Global Health and Social Medicine at Harvard Medical School in Boston. He has an extensive track record in research in the epidemiology of mental disorders, on the social determinants of mental health, especially in poor resource settings. Vikram is responsible for the very influential Lancet series on mental health in low and middle income countries, published in 2007 and then in 2011, and also is responsible of the series in PLOS Medicine. I'm sure many of you have read those papers on the packages of mental disorders. He's also one of the founders of the Movement for Global Mental Health, a coalition, a global coalition of professionals, but also of volunteers working together to support people with mental health conditions. He also wrote books, among the others, a book published in 2003 called Where There Is No Psychiatrist. And this could be quite relevant to the topic we are covering today, because in that book, he covered the idea of implementing task shifting approaches, that is shifting the intervention from highly specialized staff to lay staff with minimal training. I also noticed that 10 years ago, he was listed among one of the, in the top list of 100 most influential people by the Time magazine. So thank you very much, Vikram, for being here. And of course, Vikram hosted Davide for 2 years in Boston. So Vikram, the floor is yours.
Thank you very much, Corrado. Let me start by, first of all, saying what a pleasure it is to be a part of this seminar where we are going to celebrate really Davide's Marie Curie Fellowship, and what a pleasure it has been to work with Davide and his network of collaborators over the last 3 years. Although we're coming to the end of a 3-year fellowship and a collaboration between my lab at Harvard Medical School and Corrado's department, I'm hoping very much that this is only the beginning of what will be a much longer and mutually rewarding partnership between our communities. So, to follow on from what Corrado said, the introduction, I have made a slight change in the title of my talk, but the topic is exactly the same. And the reason I changed the title is because it, let me just remove these panels. The reason I changed the title was mainly because it reflects the title of an article that Atif Rahman and I wrote for the flagship journal of the American Academy of Arts and Sciences, Daedalus, last year. And it's called Empowering the Extraordinary. And I use the word frugal because, as you will see, this is an innovation. When we think of innovations, we often think of really sophisticated technical innovations, things that are oftentimes quite expensive. But as you will see in the course of my lecture, the innovation that I'm going to be talking about is frugal. It's extremely cheap, and it's widely available in every community that I have ever worked in. Now, most of my work really comes from India, and so I think that's a good place to begin my lecture. I want to start with the epidemiological question of the burden of mental health conditions in India. And we have a very good answer to that question from India's National Mental Health Survey. This is the latest and largest epidemiological study of the prevalence of mental health conditions in adults, and it was actually sponsored by the government of India. And in a nutshell, what the study shows is that about 100 million adults are living with a clinically diagnosable mental disorder in India at the time of the survey. But the number that's really important is this particular set of numbers that is hidden inside the report, which is the numbers of people with a diagnosable mental disorder who have not received or accessed any form of care from the healthcare system. And this number is really the staggering one. Of the 100 million people with a mental health condition, about 80% have received no care at all in the previous 12 months for their condition. And of course, this average hides huge intra-country variations. In rural areas, that proportion is 100%. And also, it hides the fact that when you're simply accessing care, it doesn't in fact mean you're receiving evidence-based interventions. And we have good data on evidence-based interventions also from India, which shows that 8 times out of 10, when you are accessing mental health care, you don't actually receive an evidence-based treatment. In other words, the effective coverage of evidence-based treatments for mental health conditions is almost next to zero. Now, this is the world's most populous country, but in fact, these numbers are also true, in fact, even worse in some instances for countries, for example, in sub-Saharan Africa, many parts of Southeast Asia, and in Latin America. So the question really is, we have this huge care gap. How do you address this care gap? Now, one common idea, especially amongst psychiatric, psychological, mental health professional communities, is that this large care gap is due to the lack of mental health professionals. And to some extent, that is true. So, for example, if I had to show you a slide of care gaps, say in Italy, for example, or in Scandinavia, or in the United States, you will find also that there are care gaps, but they're much smaller than the ones that I'm showing you on this slide. And so the assumption has been that the number of mental health professionals is an important marker or important strategy for reducing care gaps. And you can see the scale of the difference, the inequity in the distribution of mental health providers on this chart, where I have shown the number of psychiatrists on the y-axis and the population of countries on the x-axis. And on this chart, I've only shown the most populous countries in the world. And what you can see here is the US as an example of a populous, wealthy country. If you look at the number of psychiatrists, it's way off the charts almost. For an equivalent population, for a population 4 times the size of the US, India, for example, has about only 4,000 compared to 35,000, 10% really of the number of psychiatrists. And if you looked at the total number of mental health professionals, for example, including psychologists and so on, just the city of New York has more mental health professionals than the whole continent of Africa. So it's not unreasonable for us to consider that the difference in the number of mental health professionals is actually a major driver. Similarly, we in the United States, we spend so much on mental health care that by this analysis, if we include institutionalized care, we outstrip all other health conditions in terms of the per capita and total expenditure on mental health. So we spend a lot of money, and most of that money, in fact, goes either into institutionalization and or a highly specialized mental health care. So you'd expect, though, with these higher levels of coverage, you would expect that there should be some impact on population burden. Unfortunately, it turns out, at least in the US, there is no such impact. If you see here on this slide, the prevalence of mental health conditions over the last 10 odd years, you will see not only is that the average showing no impact at all, and you can see the overall in the green line here, the prevalences remain static. But in certain subgroups, for example, in young Americans, you will see a gradual increase. Actually, that increase may look very gradual, but in proportionate terms, it's a 25% increase in the prevalence of mental illness amongst adults in the United States. At the same time, mortality associated with poor mental health in the form of substance use and suicide has been rocketing up. And the biggest increase has been in young people, where suicide mortality has increased by nearly 50%. The suicide mortality rates have increased by nearly 50% in the last 2 decades. And on any given day, there will be more people with serious mental illness who are locked up in a prison in the United States than they would be in any kind of healing, a place of healing, such as, for example, a hospital. In the words of one of the most prominent psychiatrists of the United States, Tom Insel, who led the National Institute for Mental Health, not only did we spend a lot of money on mental health care, largely, as I said, on hospital care and on psychiatric care, but we also spent a ton of money on research. And in spite of all that research, we have come up with almost nothing really transformative in terms of either prevention or therapeutics over the last 25 years. And of course, during the same period, every metric, as I showed you, on population mental health has only gotten worse in the US. Now, honestly, the fact of the matter is this is not the kind of grim statistics that you would see if the director of, say, the National Institute of Cardiometabolic Disease was presenting his findings. He would basically show that over the last 2.5 decades, cardiovascular disease incidence and mortality has been falling. If you are the National Cancer Institute director presenting, they'd say, in the last 25 years, there have been transformations in our understandings of the etiology of cancers, preventative interventions, and therapeutics. And in fact, cancer mortality across most types of cancer have also been falling. So there is clearly something problematic about the way we approach mental health care when we adopt the model that seems to have worked so well for cancer and heart disease, and we apply that in the mental health space. And this is a question that we grappled with in our paper in 2023 in the Lancet. And we came to the conclusion when we looked at a large amount of different forms of evidence, a lot of it subjective and qualitative, but a lot of it also empirical. And we came to the conclusion that a very narrow biomedical framing of mental health, as I said, which has worked really well for cancer, which involves the diagnosis and the treatment of disorders that are biomedically defined, has failed us. And it's failed us because it's led to the privileging of a very narrow set of ideas of biological mechanisms. Tom Insel himself in a mea culpa said his definition of mental health conditions as brain disorders was fundamentally wrong. Of course, mental health conditions involve dysfunctions in brain function, but it doesn't mean that those dysfunctions arise in the brain. And so the psychosocial mechanisms have often been ignored. We have focused much more on acute crisis management rather than the continuing care that we know is necessary for recovery. And of course, that's because psychiatrists largely work in hospitals, and that is where crises largely present, rather than a team-based approach with a strong community orientation. And that we are more focused on clinical phenomena, such as, for example, the symptoms of depression, rather than recovery. What might be a different way of thinking about how we can address mental health problems that addresses these other ways, these other paradigms that are so important? About 25 years ago, I began my journey in global mental health. At that time, there was no discipline called global mental health, but there was an emerging discipline of global health. And a key area of research that I started looking at is how do countries with very few resources address other health problems. Back in the 90s, mental health in developing countries or in the global south was on no one's agenda. But there were many other health issues that were on people's agenda, like TB, HIV, maternal mortality, neonatal mortality. And I started asking the question, of course, we had no psychiatrists in most parts of India, but we also had no pediatricians, we had no gynecologists. And so I started looking at how rural, remote, and under-resourced communities in India were addressing these extremely critical health problems. And I came across a range of different ideas that were captured in this book, which for me is one of the classics of global health, but it was published in the 1980s. And it was a series of case studies on how rural communities were organizing themselves, often led by very inspiring physicians, to transform the healthcare systems in the absence of specialists, in the absence of a robust health infrastructure. And one such example was a program that focused on reducing maternal and newborn mortality. And here you can see a picture of a woman. This woman in the orange is a health worker. But what you can't really know is that she's in fact a local woman with no prior training in health. In fact, she hasn't even gone to school because in most of these tribal villages, there are no schools. And so she can't read or write. But she has been trained to do a number of essential tasks to do with maternal and newborn care, such as what you can see here is conducting a practice exercise of weighing a baby. But she was also trained to detect and treat newborn pneumonia and sepsis, the leading cause of mortality in the first month of life. And the idea was there were no neonatal intensive care units, there were no pediatricians. So in this extremely rural and remote part of India, the inspiring leadership of two physicians who had returned to India after doing their masters in public health in Johns Hopkins University was that they would use local women, simplify the diagnostic and treatment protocols for newborn pneumonia, and make them accessible to these local women whose only qualification was that they lived in the local villages, they spoke the language, and they themselves had experience of motherhood. And they were trained to diagnose and treat pneumonia using the evidence-based practices that pediatricians would use. They then ran what has now become perhaps one of the most iconic randomized controlled trials from the global south. In fact, a few years ago, when the Lancet was celebrating, I think its 100th anniversary or its 200th anniversary, they identified the 10 most important papers ever published in the Lancet, and this was one of them. They showed that this kind of program led by women like Anjana, who's the woman who I met actually many years later, since the trial, were able to reduce neonatal mortality rates by 25% in 3 years. And then they also reduced maternal mortality rate by more than 40%. A single trial doesn't change practice, of course. So the Indian Council for Medical Research then funded a set of replication trials. The WHO funded a number of trials in East Africa, in South Asia, and Southeast Asia, all adopting this kind of approach of delivering maternal and newborn care at home, because there are no hospitals, in the hands of appropriately trained and supervised frontline workers with no prior training in newborn or maternal care, and using evidence-based protocols that would be widely accepted in more formal clinical settings. Those trials replicated these findings, and today this is the largest government-led program in India today, which, as you can see from the guidelines of this program, is home-based newborn care. And this is a very radical idea, moving care away from the hospital to the home. And you'll see this now happening across other areas of global health, such as TB and HIV care. Just last week, a colleague from the Mass Gen Hospital was presenting her findings on a large NIH-funded program examining how antiretrovirals could be delivered to people in South Africa and in Uganda, and coming to the conclusion through a large trial that when you deliver these medicines at home, you actually improve clinical outcomes. You reduce mortality, you improve viral suppression rates. In other words, it's a complete change of our thinking of how and where and who can deliver care. So I adopted these very ideas, and of course, at the heart of that is simplifying the treatment protocols. I adopted these ideas, in the early 2000s and began experimenting with how we could take this rich body of knowledge that was emerging from areas like HIV, TB, maternal and newborn care, how we could apply that to mental health care. And one of the early interventions that I developed was to develop a treatment for severe depression that could be delivered in primary care, a brief treatment that was based on local practice as well as global evidence. And we arrived at a treatment called the Healthy Activity Program, which was a 6-session treatment for depression. The trial findings were published in the Lancet in 2017 and the follow-up in PLOS Medicine in 2019. And I want to show you a brief video that illustrates the experience of the delivery of that treatment.
पहिले म्हाका खूप त्रास आहे 2 वर्सां जाली तकली दुखा आनी चक्कर येयल्यासारकी जा डेली तकली दुखा डेली घरातले कसले काम जायना जाय न्हिजोन रावा दिसभर भुरग्यांक सुद्दां मी लागी घेयना जाय कित्याक घरातले करिना जाय
म्हाका खूब त्रास करता घरा देव आनी तेजी बायलूय शिकयता आनी म्हाका खूब टेंशन जाता तकलेन आनी हांव बरें नासता म्हाका जेवपाची बी याद उरना आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांव केन्नाच सारकें वाडिनाशिल्लें कांय करिनाशिल्लें तांकां एक कितें करप आनी कितें घातलें आनी घालप आनी टायमूच म्हाका असो बसोनूच हांवें काडप म्हाका खूब टेंशन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do. For example, there may be social withdrawal, they may not be able to keep up with their work demands, they may stop doing pleasurable activities like watching TV, reading, etc. The less they do, the worse they're likely to feel. So the Healthy Activity Program is delivered over about 6 to 8 sessions. So the main focus of the initial sessions is to get patients to become activated, to start doing things that we know will help them feel better.
कितें काम कर म्हणजे मागीर थंय रोंपो लायलो मातशें अशें भोंवंक वचूंक लागलें जावं काटयां हाडूंक लागलें शेतान मातशें वचोंक लागलें आनी कितें भाजी पालो घरा कडेन रोवंक लागलें आनी तितून मात मागीर म्हाका म्हयन्यान करून म्हाका एक 9 म्हयन्यांनी सारकें पूर्ण तकली म्हाजी शांत बरी जाली.
पयलीं तेणी 5 मिनटां कुळागरां वचून काम कर म्हणलें मागीर तेणी म्हाका 10 मिनटां दिलीं मागीर 15 मिनटां दिलीं मागीर म्हाका तें काम बरें जाता अशें दिसलें हांवें 5 मिनटां 2 मिनटां वाडोवन करप मागीर म्हाजी भुरगीं येतालीं मदत करून आनी इतल्यान म्हाजें आतां कुळागर निव्वळ आसा आनी म्हाजें कामच चालू बरीं जाता आनी म्हाका आतां वखद सुद्दां नाका बरी जाली तितूंतल्यान आनी बरी आसा हांव सामकी.
आनी आतां म्हाका खूब बरें दिसता जशी तकली जास्त दुखना केन्ना अशें चुकोन दुखता बेगीन उठपाचें भुरग्यांक शाळेक धाडपाचें जाता त्रास जाय तकली बी दुखना आदल्या सारकी.
Such a simple intervention, a simple psychological technique that is embedded in the social world of these patients. And yet, the impact has been staggering. Remember, these are not just people with mild to moderate depression. These are moderate to severe depression. In primary care, none of these patients had received any depression care in their lives before. The treatment was delivered over 6 sessions, 30 to 40 minutes each by lay people. And you can see 2/3 of people recovered in the treatment arm and stayed well 5 years later. Of course, you always see a natural remission rate, but you can see that it remains extremely, the recovery rates were much poorer in the control arm. And the control arm was not just no care. This was typically doctors who had been trained in the MHCAP protocol of the WHO to provide antidepressants. Now, the other important point I want to make is not only that 2/3 got better with this approach, but 1/3 did not. And I'll return to this point, how important it is for us to be thinking about mental health care as a team-based approach with a stepped care modality that ensures that everyone receives care, which is low intensity, but at the same time, those who don't respond can be referred to the specialist. Sangat, the NGO that I co-founded in India back in the 90s, has now become one of the world's pioneering organizations to design, deliver, evaluate, and scale up psychosocial interventions for a range of different mental health related issues, from prevention and promotion in schools to recovery for people with chronic enduring schizophrenia, and across the life course from autism to dementia. All of its trials are now regularly published in some of the world's leading journals. And this evidence base has been further supplemented by a large body of trials, more than 100 now, from other countries, from other organizations, including, for example, the Friendship Bench that you can see here from Zimbabwe, where grandmothers from the local community were trained to deliver a 6-session problem-solving treatment for depression and anxiety, sitting in benches that were erected in the gardens of clinics in the capital city of Harare. Why benches? Well, because the weather is very good in Harare around the year, but also because the clinic that you can see at the back there are very, very busy. So the net result is now systematic reviews. And of course, David has been doing a systematic review and a meta-analysis, a component meta-analysis. No doubt he'll be describing that a little later this morning. But in that, you will see not just the wealth of evidence, but by using an individual patient-level meta-analysis to be able to unpack which are the active ingredients or components of the psychological interventions that are the most important in terms of effecting clinical change. Now, it's important to say that this approach is not only true, not only useful in places like India, but as my colleagues Paul Farmer, the late Paul Farmer, and others have written, how such community health promoters, or in the use of the Haitian word, accompagnateurs, provide directly observed tuberculosis treatment and HIV care, and how they're not just an alternative. They actually provide more than the routine clinical care, offering psychosocial support. In Paul's own words, to be an accompagnateur is to accompany someone, is to go somewhere with him or her, to break bread together, to be present on a journey with a beginning and an end. And this is really at the heart of so much that is missing in mental health care, because in mental health care, we're treating episodes of illness rather than genuinely accompanying a person, oftentimes for extended periods of their lives, as they struggle with and ultimately achieve the goals of recovery that they have. This large body of evidence has now been embraced by a range of different major institutions, such as, for example, the World Bank in its Disease Control Priorities Program, the World Health Organization's Independent High-Level Commission on NCDs, and of course, several Lancet commissions and the World Mental Health Report, essentially embracing the notion that every mental health care system must have at its heart, the foundation must be a foundation of frontline workers who can accompany people on their recovery journeys. Frontline workers who can both provide early intervention in the form of indicated prevention, as well as after a crisis, who can support an individual to ensure that they remain relapse-free and ultimately recovered. Importantly, this is also now being recognized in wealthy countries. For example, this particular manual that was produced by the Mayor's Fund for New York City that really documents how one can implement this global frugal innovation in the world's wealthiest and best resourced city, New York. In fact, now this particular approach of diversifying the workforce has become part of the US federal government, as well as states across the US. It's become part of the standard approach to mental health care. And my lab in the United States that Davide was part of for the last 2 years is actively working on building out the curricula and the tools, mostly using digital platforms, in order to rapidly build the capacity of frontline workers to deliver a range of interventions for depression, for emotional disorders in adolescents, for peer support, for people with enduring mental illness, and so on. And as Davide said, the second edition of my book, which was released a few years ago, really embraces a lot of this science in a clinically oriented manual for frontline workers who find themselves working in places, not necessarily where there is no psychiatrist, but also in places where there is a psychiatrist, but where the role that they play is complementary and additional to that of the psychiatrist. The work that Sangat has been doing is transforming mental health globally. Here you can see examples of a range of interventions that have all of them which have been designed around the idea of empowering frontline workers, oftentimes lay people from communities, to carry out a range of tasks that would have historically been done by highly trained specialists in hospitals. For example, the assessment of early life cognitive development, which is a critical pathway between early life adversity and later life mental health, traditionally done in specialized settings by developmental psychologists over several hours of assessment. Now we have a digital tool that allows parents themselves to directly assess the cognitive development of their kids. And this tool has been exported to a number of different countries, including, for example, in Malawi, where the tool has been shown to work to detect early life brain development. Similarly, a variety of other interventions for autism, for school-based health promotion, which is now being implemented in the United Kingdom and in Japan, in the city of Tokyo. This just indicates really the appetite of even wealthy countries to start embracing these frugal innovations that rely on a much more plural workforce and simpler technologies for delivering evidence-based care. In the US right now, I'm very excited that we're in the midst of a major scale up of the Healthy Activity Program, which has been adapted for delivery in the US in both Spanish and in English through a range of partners, hospital systems, faith-based communities, and universities working across the state of Texas. Another example in which this is also being embraced by the science community is the Summit trial, where the same behavioral activation treatment that I mentioned, the Healthy Activity Program, was adapted for delivery for mothers with perinatal depression. But here the trial was asking even a more provocative question. In the trials in developing countries, the usual care is usually a doctor or a nurse who is trained in MHGAP. But here what we're really asking is, can we show equivalence between the frontline worker delivery against a specialist, a psychologist or a psychiatrist, delivering the same treatment to the same patient population? And this is a much more provocative question, but one that's very relevant to a country like the US and Canada, where this trial was conducted, where there are a large number of specialists and there are a lot of licensing and legal concerns about the safety of using non-specialists, which in this instance comprise nurses, midwives, and doulas, which are traditional midwives. The findings of this trial were published in Nature Medicine a few months ago, and what they showed was that behavioral activation delivered by frontline workers with no previous mental health training were equivalent in effectiveness to those to the treatment being delivered by psychologists and psychiatrists. So it isn't just the case that these frontline worker delivered models are better than no care or usual care. They're actually as good as specialist care. And this should give us a moment to pause and reflect on really the power of this frugal innovation to dramatically increase access to mental health care in all countries of the world. We can see this evidence as redefining mental health care in 4 ways. Firstly, a mental health intervention doesn't always have to be very complicated. It doesn't always have to involve several months of therapy. It doesn't always have to involve a medication protocol. It can often be a brief psychosocial intervention, because for a large proportion of people, that is oftentimes the only thing that they actually need to help them get them back on their feet and recover at their own pace. The intervention doesn't have to be delivered in hospitals. As our colleagues in TB, in HIV, in cardiovascular disease, and other areas of medicine are showing, the interventions can be delivered where people are. And this is especially important for mental health care, where often the mental health condition interferes with the ability of patients, for example, to travel, to keep appointments, etc. So deliver care where people are, in schools for young people, at home for people with schizophrenia. On the digital world now, of course, with telemedicine, increasingly for people who can't travel to clinics. 2, well, I hope you've been convinced that it could be anyone in the community who has been provided appropriate training and supervision and is always supported by the mental health system, because collaborative care is critically important. Support, supervision, and referral pathways are centrally important for these kinds of models of care to work. Remember, this is not about replacing mental health professionals. This is about expanding the reach of mental health professionals and enabling those mental health professionals to work at the top of their license, at the top of their expertise, focusing their skills on those individuals with the most intractable, severe mental health problems, which is not responding to a first step of care that is delivered by frontline workers. In the Lancet 2023 paper, we demonstrate what the architecture of care might look like in the context of the science. I haven't presented to you any of the findings on serious mental illness, but there is a whole parallel body of research on task sharing and community-based care for people with chronic enduring schizophrenia. And what we arrived at two different models of care. One for people living with common mental health problems, such as mood and anxiety problems, where we see primary care as the primary focus or the nodal agency for care, supporting frontline workers who are supporting people who are living with depression and anxiety in their communities. And then for more serious mental illness, we do recognize that the evidence shows the need and importance of pharmacological care as well. And this is ideally done by mental health professionals in hospital settings or clinical settings, where you also have short stay inpatient units. But once again, they are supporting frontline workers that are supporting individuals with these disabling and enduring mental health conditions towards their recovery path. So you can see collaborative care is very important as well, particularly for mood and anxiety problems, because oftentimes there are individuals who may also need psychiatric or psychological care. In this diagram, you will also see the key role of bolting on to the mental health care system a range of other sectors in which prevention and promotion can take place, for example, in school systems and the workplace, and where recovery journeys are often needing social interventions, such as, for example, housing and residential support. And so this diagram is intended to capture the entire architecture of what a mental health care system can look like, deploying connections between different sectors of the healthcare system, the specialized primary care and community care, but also different sectors of the government, because we know from the evidence that a medical approach alone is inadequate to ensure the best outcomes for people, particularly with enduring mental illness. To end then, what I hope this evidence shows us is the need to reimagine care, not by focusing on a person's diagnosis, by adopting a one-size-fits-all, but by focusing on a person's needs. And I know that all psychiatrists and psychologists already do this in their daily practice, but yet at the level of the structural approach to mental health problems, the diagnostic approach still seems to be extremely dominant. We need to move back to the way that we have always worked historically with our patients, is by formulating an individual in the context of their life story, in the context of their clinical presentation, in the context of their social, cultural, and economic factors, and plan a treatment strategy that is aligned with their needs. Almost always that means to organize care in a step care fashion, built along a strong foundation of primary care. And by primary care here, I'm referring not just to the primary care clinic, but I'm referring to primary care as a concept that also means care that extends into the community, even to the household, to the individuals. And therefore, to do that, we need to empower members of the community with knowledge, with skills, with resources, and in the case of more formal community-based providers like peer support workers or community health workers with career pathways, make them respected members of the health team, the mental health team. And lastly, of course, we must always retain a very high importance on questions of accountability and equity. And this is especially important in mental health, because we know that mental health problems do not affect all people in an equitable way. People living in conditions of disadvantage on the margins of society are much more prone or vulnerable to develop mental health problems. And these are the very groups who often do not receive the same quality of care. It's very important in our mental health programs, with a focus on the population and scalability, we need to have an equally important focus on accountability and equity. So thank you very much, and I hope I've left enough time for some questions and discussion. I'm going to hand it back now to Corrado and Davide.
Thank you. Thank you very much, Vikram, for your very clear presentation and